Hello, Dr. Subhadeep. Are you there? Dr. Subhadeep?
We can start.
I'll start with the present introduction. Good evening, everyone. Today we have our esteemed speaker, Dr. Gunadhar Padi. He is the senior consultant critical care at Apollo Hospital and involved in heart transplants and lung transplants. Also, he has extensively, spent his lot of time in hemodynamic monitoring, and it would be worth hearing from him today to understand the basics of hemodynamic monitoring. And with me, Dr. Subhadeep, he is also consultant critical care at Apollo Hospital, will be joining. And myself, Dr. Akhilesh Tandekar, critical care consultant at Apollo Hospital, would be moderating this session today. So with this brief introduction, I would like to invite Dr. Gunadhar for his presentation. And at the end, we would be happy to take questions. So basically, we would be taking questions which will be useful to the DNB students as to what questions are asked in the exams. Pertaining to that, some of the questions will be taken at the end of the lecture. So can I invite Dr. Gunadhar for your presentation?
Yeah. So, thank you, Akhilesh. Actually today, because of the busy schedule of our previous speakers, so basically we are not able to conduct these lectures. But definitely we will be like to invite them in our future courses like advanced hemodynamic monitoring. So I'm audible?
Yes, you are very much audible.
Yes, sir, you're audible.
Okay. Thank you. Yes, thank you. So basically we have divided this hemodynamic series into 3 classes. One is the basic monitoring, and second is the advanced monitoring, and third is followed by the intervention. So what interventions the patient needed. So today we are going to speak, or I'm going to speak the very basics of hemodynamic monitoring, which is very much required at the bedside. And this is basically something called as the skills of the intensivist, and those skill sets are very, very important to patient's outcome. So that is the reason my topic will start from the very basic clinical hemodynamic monitoring and basic monitoring which you do in the bedsides, like arterial pressure tracing and how to interpret them, fluid responsiveness, the CVP monitoring, what are the evidences, and what are the other newer bedside monitoring tools to monitor the global and regional circulation. So this goes by the famous, quote by Pinsky and Payan that no monitoring devices, no matter how simple or complex, whether it is invasive or non-invasive, inaccurate or precise, unless until improve the patient's outcome, it is not going to solve our purpose. So the most important part here is that every hemodynamic monitoring should be well correlated and it should be well interpreted. And the main aim is to determine what intervention the patient is required for that particular purpose. Then only it will improve the outcome. So clinically, hemodynamic monitoring is nothing. Basically, it is the monitoring of circulation to perfusion. So whatever the circulatory system, whether it is in the right health or whether the organs are getting well perfused with good circulation. That is what basically the summation of the hemodynamic monitoring. So it basically starts from the heart and cardiovascular system. It goes to the arteries, then both are interconnected, and then it leads to all the associated organs like sympathetic nervous system. Then all 3 are interconnected and followed by something called as the chain, and the chain reaction goes on, and finally the organs and tissues, they get perfusion. So that is the reason, and all the venous or the blood which is drained from the organ and tissue, it again goes back to the heart and cardiovascular system. So this is how we divide all these things into cardiac output. So the most important monitoring is whether the patient is getting adequate cardiac output or not. Okay, and ultimately what we monitor is whether the cardiac output is adequate, whether the tissues are well perfused, whether the regional oxygen circulation and the global oxygen saturation are at our health. That is what is more important. So if you divide it, so this part is called the circulation and this part is called the perfusion. Like the circulation consists of arteries, heart, your cardiovascular system, your veins, and organs are the end organ of the perfusion. So why hemodynamic monitoring? So this is the basic tool. So what are we really worried about is basically the tissue hyperperfusion. So any tissue which is hyperperfused is basically leads to tissue dysfunction or cellular dysfunction, and that leads to organ death and your organ dysfunction. So what we really want to monitor is adequate oxygen delivery, and inadequate tissue perfusions combined with hypoxia that affect the multiple organ system. So this is the whole and gist of the hemodynamic monitoring. And what we remember is that there is nothing term called as normal cardiac output. So either the cardiac output is adequate to meet the metabolic demands, or the cardiac output is inadequate to meet the metabolic demands. So what are your goals of monitoring? Basically, monitoring are very few. First thing is to ensure adequacy of tissue perfusion, early detection of inadequacy of perfusion, to titrate the therapy to specific hemodynamic endpoints. So the intensivist is concerned, what are your endpoints? Where you need to stop the fluid, where you need to give the fluids, and what is your endpoints of hemodynamic monitoring? That is very, very important. So to differentiate among various organ system dysfunction is also one of the goals. Like one should be able to understand whether the organ dysfunction is at the level of the kidney, at the heart, at the liver, or it is in the level of the microcirculation or microcirculation. So every patient is different, every individual is different. That is why not all the monitoring suits to all patients. The hemodynamic monitoring should be individualized. It should be physiologically based, and it should be goal oriented. Then only it will serve the purpose. So the most important thing is how to improve the outcome. So that is the most important point of any monitoring devices. Unless until it improves the outcome, then there is no point in monitoring something. That is why whenever we monitor something, we should be very, very careful. Our goal should be very clear whether it is going to improve the patient outcome or not. So that is where the clinical assessment is the first tool. You have to assess the patient, then followed by basic hemodynamic monitoring tools, whether this patient needs hemodynamic monitoring or not, and then followed by whether we really want to do any advanced monitoring devices or advanced monitoring, hemodynamic monitoring for that patient or not. That we want to determine. And the final goal of any hemodynamic monitoring is therapeutic intervention. So what therapeutic intervention you are planned with these monitoring devices, that is more important. Unless until you want to institute some therapeutic intervention, then there is no point in doing very hi-fi monitoring or hi-fi gadgets. So that is why the good clinical examination and the key, and the good clinical examination and the least invasive monitoring devices is very much important for bedside monitoring of any hemodynamic monitoring. So what are the indices of hyperperfusion? So clinically, if you see, these are all small subtle signs which tells us that this patient is having tissue hyperperfusion, like thirst, cold extremities, poor peripheral pulses, impaired capillary refill time. And these are the certain other clinical parameters which tells us that this patient is also under threat. That means tachypnea, any high respiratory rate, tachycardia where the heart rate goes high, any confusion, if the patient is confused, altered, or if there is an altered skin perfusion and low output, those are the signs that tells you that there is definitely some problem in the patient, and this patient definitely needs extensive monitoring, and he's basically in a state of inadequate global perfusion state. These are the different indications of low cardiac output, like bradycardia, where the heart rate is less than 40, or ischemic chest pain, which also tells the intensivist that there is something wrong undergoing in the particular patient. So skin perfusion is always a very important marker. It is one of the surrogate marker of any hemodynamic monitoring. So altered skin perfusion is difficult to quantify, but it is a sign of altered tissue perfusion is very much alert to the intensivist that the patient is in a hyperperfusion state. So classically, if we see in the early stage of septic shock, the skin may be flushed, warm, vasodilated, and this is called the vasodilatory shock. While in the later stage of most of the shocks, the extremities may become very much cold, clammy, and the patient ultimately go into some kind of circulatory failure. That is why to identify the earliest signs are very, very important. Most of the times in our ICU, we see such kind of marks on the skin. And these are those marks that tells us that this patient is in severely underperfused state of the skin. And skin is one of the largest organ in the body. So if you see, these are called the mottling signs, and these are graded according to 0 to 6. So these mottling signs basically tells us that the patient is having hyperperfused state. So if you see, basically the score 0, where it says that there is no mottling, and score 5, where that says that it is extremely severely mottling area extending beyond the groin. And this is basically the grade 2 mottling, where there is a small area of mottling localized to the center of the knee, or modest mottling area that doesn't extend beyond the superficial area of the knee. So these are the grade 2 mottling. So this can extend up to grade 3, grade 4, and severe grade like grade 5. Higher the mottling score, correlating with increased mortality in the critical care patients, and this is a proven fact. Organ-specific assessment, something called as urine flow, basic and the best predictor of organ-specific hypoperfusion is a very good urine output. So normally we aim at a urine output of minimum 0.5 ml per kg per hour. If it is less than that, probably this patient is going into shock, because we know that out of all the cardiac output, 25% of the cardiac output goes to the kidney. So almost the status of the kidney reflects 1/4 of the cardiac output, and the perfusion of the whole body is almost 1/4 of the perfusion of the whole body is signified by the kidney perfusion. That is why it is very important to maintain the hourly urine output at least 0.5 ml, more than 0.5 ml per kg per hour. And probably this is not a very much sensitive or specific test. It is a sensitive test, but it is not very much specific, because there are a lot of pitfalls, like if the person is taking diuretics, if the person is inotropic agents like dopamine, if the person is dehydrated, or if the person is under all this heavy dose of alcohol intake, caffeine, then the urine output actually sometimes it's not very much reliable. And those cases are ideally have to be taken very much seriously. Organ-specific assessment. So conscious level, basically we know that an awake patient is the best patient who can tells you that the hemodynamic monitoring is going smooth, and the person itself tells you that he is in a very good shape and he do not require any kind of additional monitoring per se, unless until there is some other organ dysfunction. Hypotension, it is one of the sign, though it is not a very earliest sign. But sometimes if hypotension develops, probably the patient is under the underperfused state for almost 6 to 8 hours. So there are two types of hypotension I can say. One is called the high output hypotensive state, and second is called the low output hypotensive state. So in high output hypotensive state, the patient is in the hyperdynamic circulation, having a bounding pulse, but he is hypotensive. He has a pulsatile pericardium, precordium, dilated peripheral vessels, increased pulse pressure. The peripheries are warm, particularly seen in a case of septic shock. And there is other types of shock where the hypotension is manifested with very low cardiac output state, and where the person is having bradycardia with hypotension. In those cases, the peripheries are cold and there is constricted hand veins. There is a narrow pulse pressure and very thready pulse, which is basically a late sign of end organ failure. That is why these signs, once it appears in a patient, it tells you that the patient is almost going to a state of irreversible shock. Pulse is always an important reflection of hemodynamic status. And these are the different kind of pulse. Somebody has to identify something called as weak thready pulse to full bounding pulse. These are the different tracing of the pulse one has to know. And this weak thready pulse is a sign of low cardiac output, and it's also a sign of severe other cardiovascular system problems like severe aortic stenosis or sclerosis. One has to really very much careful to palpate such kind of pulse, because sometimes these pulses may not be noticeable properly. The full bounding pulse, in contrary, it shows that it is the earliest sign of shock, where it's a sign of hypercirculatory state, like patient in early sepsis, patients who are doing exercise, anxiety, patient with fever, anemia, hyperthyroidism. These pulses can feel bounce to your finger, and these are the pulses which can easily appreciable. There is something called as pulsus paradoxus, which is also will play a very important role in hemodynamic monitoring. Like most of the times during inspiration, the pulse volume goes down, and during expiration, the pulse volume goes up. This is something, the characteristic pulse, which is called as basically the early sign of pulsus paradoxus. But the more important thing is when we measure the blood pressure in such patients, if there is a inspiratory and expiratory variation of blood pressure of more than 10 millimeter during inspiration and expiration, this is something called as pulsus paradoxus. And all of us know these are the important signs which tells us that this patient is in early cardiac tamponade, or something kind of like your severe bronchial asthma or status asthmaticus. So the dictum is that when you measure the blood pressure during inspiration and during expiration, and probably during inspiration, the blood pressure falls significantly, and during expiration, the blood pressure rises. These are the signs that tells you that this patient is in kind of something called as pulsus paradoxus. Jugular venous pressure, everybody knows how to assess it. Basically, there are two types of JVP. Either the JVP is raised or the JVP is normal or collapsible. Most of us have a collapsible JVP, but that doesn't mean that we are in hypotensive or we are in shock state. But something, when the JVP is raised, those signs tells you that definitely there is some element of cardiac failure or some element of congestion of the veins, and that needs to be taken into account. Absence of jugular venous distension in supine patient, that suggests that this patient JVP is low. Something we can elicit the jugular venous pulse by doing a hepatojugular reflux or measuring the jugular venous distensibility, or when the patient is in by means of ultrasound. So the jugular venous distensibility is now considered to be one of the important signs of fluid responsiveness, in at least in patients, which can be used as a screening test in most of the centers. Though these are not very sensitive or specific, but out of curiosity, somebody can measure the jugular venous distensibility and determine the hydration status. Capillary refill time or nail blanch test, as we all know, this is one of the very, very important tests. So if the blanch time of capillaries are greater than 2 seconds, or if it is more than 3 seconds, it something indicates shock, peripheral vascular disease, or severe hypothermia. There are trials which clear-cut proven that if the person has a delayed capillary refill time, it increases the mortality. So there are a lot of trials like Andromeda shock trial, which can basically focus on the capillary refill time. The normal value does not exclude the hypoperfusion. This is the most important point. So these are the different literatures that shows that a prolonged capillary refill time is a predictor of low central venous oxygen saturation. So we'll go to the next topic, what is actually low central venous oxygen saturation. So these are the conclusion drawn from the study, that prolonged capillary refill time more than 3 seconds or 2 seconds is a predictor of low central venous oxygen saturation, particularly in pediatric patients who are admitted to ICU, and they are the surrogate marker of the something called as the hypoperfusion state. Capillary refill time exploration during septic shock, it is also a clinical reproducible parameter, and when measured on the tip of the index finger or the knee area, it can definitely show the extent of shock or the extent of hypoperfusion state in a patient, and sometimes it is a strong predictor of 14-day mortality. Assessment of dehydration and hypovolemia, we all know these are the clinical signs. There is an increase in the something called as decreased skin turgor, and the skin remained elevated after being pulled up for a long time, and these are the signs of early shock. Similarly, the sunken eyes, the dilated pupils, swallow breathing, the pale skin, patient will feel thirsty, nauseating, patient can have severe signs of vomiting, and the pulse is very weak, rapid, and thready. These are the signs of late stage of dehydration and hypovolemia. The fluid overload states not to be easily missed, like something called as this kind of pitting edema in the hands, particularly in the something called as the dependent area, which is the most important part. And the X-ray, sometimes you can see also bilateral congestion of both the lower zones, or something called as your bilateral basal edema or curly B signs. Curly B signs are very much specific, particularly in the X-ray of pulmonary edema. And these are the signs of heart failure also. Cyanosis particularly suggests towards the lower hemoglobin, or something called as the deoxygenated hemoglobin, when it is present more than 5 grams per deciliter in the blood. And when the oxygen carrying capacity goes down, like most of the cases, the DO2, when it doesn't match with VO2, then those patients are considered to be in the shock. Core to peripheral temperature difference. Normally, there is a central to peripheral gradient of around 4 to 5 degrees centigrade. If you measure the core temperature and peripheral temperature, normally 3 to 4 degrees centigrade is acceptable. When the peripheral to ambient gradient is more than 5 degrees centigrade or less than 2 degrees centigrade, that is something abnormal in that particular patient. So this is something called as vasoconstricted state, where you find the core temperature is more and the peripheral temperature is less, and the gradient basically increases. And just to the opposite of vasodilatory state, where the core temperature is less and the peripheral temperatures are more, and the peripheral to core temperature gradient decreases. So these are the very subtle signs or early clinical signs one can elicit in the bedside by measuring the temperature. But the pitfall is that if the person is having a peripheral vascular disease, person is already suffering from central hypothermia by some kind of sedatives or hypothalamus dysfunction, then these are not the reliable signs. If the person is on use of vasoactive drugs, these are also not the very much reliable signs. So these are the papers which shows that the central peripheral temperature gradient is value and in limitations in the management of critically ill surgical patient, particularly this study, though it is an older study, but it cannot be neglected. Similarly, there can be simple measures like two to core temperature difference, which also can be taken as one of the surrogate marker of severe hyperperfusion. And these are the papers in late 90s by Jolly and Well, who they have produced, and basically they have shown that there is a significant correlation exists between the cardiac output and the toe temperature. And the toe temperature is a reliable indicator of cardiac output, and indirectly it's a measure. Though now nobody has measuring all these things, but this definitely has some value. So what are the clinical assessment? The advantage of clinical assessment is that it is one of the tests which give you early signs at bedside, immediate results. Sophisticated equipments are not required. These are very inexpensive, and the clinical skills of the intensivist matters a lot. The disadvantage is that individuals have very poor sensitivity and specificity. It is inaccurate. It cannot detect small changes. There is an inter-observation variation and very limited role in perioperative patients. Like many of the patients who are subjected to vasodilatory action of anesthetic agent, hypothermic, or there can be some neurosympathetic and humoral stimulation is there. Those cases, they cannot give you with reliability that these are the signs which can show you hyperperfusion state. But the sensitivity, if you see, is almost very good, almost in the point of 70 to 80%, with specificity of around 30 to 40%. So in a nutshell, these are the small clinical examination. What we exactly see actually is the tip of the iceberg. There can be a lot more things hidden. And I'm sure a very good clinical bedside examination is the key to success and outcome of the patient. So these are the basic tools. And so the clinical examination, if I consider a pyramid, this is the top of the pyramid. And the bottom lies in the all advanced hemodynamic monitoring, like cardiac output monitoring, invasive or non-invasive. And in between lies the basic tools and the lab values, and one has to know the proper interpretation of basic tools and the lab values. So basic monitoring like ECG always suggests arrhythmias like tachyarrhythmias and bradyarrhythmias, which are always suggest that there can be some alteration in the cardiac output, because we know that cardiac output is nothing but stroke volume in the heart rate. So when the heart rate changes, ultimately it leads to change in the cardiac output and leads to change in the stroke volume. So the more important thing, always see for the lead 2 for any kind of arrhythmias, and lead V5. The lead V5 ECG gives almost more than 80% detection of left ventricular ischemia if there is such ischemia exists. So always monitor the lead V5 in your patients, and always monitor the lead 2 for different kind of arrhythmias. Always take a 12 lead ECG, because this is one of the vitals. But obviously the ECG is not free from artifacts like cautery, like hypothermia, like electrical connections. And if the patient is already with a temporary cardiac pacing, probably sometimes the ECG can misdiagnose or mislead you. Blood pressure monitoring, because we know the blood pressure monitoring depends on the cardiac output and systemic vascular resistance. So any patient where the SVR changes or the cardiac output changes, that leads to change in the arterial blood pressure. But what is more important is the mean arterial pressure, because it is actually an approximation of organ perfusion pressure. So what we should aim at is actually not to look for systolic or diastolic pressure, but to look for the mean arterial pressure, because it is ultimately the end organ pressure and end organ perfusion pressure which is reflected by the mean arterial pressure. So tissue hyperperfusion may exist in the presence of reduced, normal, or elevated blood pressure. So high blood pressure doesn't mean that your patient is not in shock. This is one of the important take-home message. Also, normal blood pressure doesn't mean that your patient is not in shock. So these are the two important things that one has to correlate clinically along with other parameters. So many of the times we see that the patient is in compensatory state in the normal blood pressure, but actually his lactates are elevated. He is in shock. That is why simultaneous recording of ECG and invasive blood pressure may reveal important information about the stroke volume. What are the different methods of measurement? Somebody may have to ask you in the Viva when you face the blood pressure tape, your OSCE station. Like these are the different methods. One is called oscillometry, second is called auscultatory, third is called combination of both. So oscillometry method is the most common method. This is basically the automated method. So here the mean arterial pressure is most accurate, but the diastolic pressure is the least accurate, and the systolic pressure varies in between. That is why whenever you measure the blood pressure with a oscillometric technique, always look for the mean arterial pressure first, then systolic pressure, then followed by the diastolic pressure. Auscultatory method, always with the manual devices. We all know, nothing to be discussed regarding that. But the important thing is, whenever we find a difference of blood pressure in both the arms, particularly both the upper limb and lower limb, always think for peripheral vascular disease, whether the patient is in aortic dissection or there is some kind of abnormal congenital heart disease. Most of the time we do not measure, we do not tell our staff to measure the blood pressure in all the four limbs, upper limb and lower limb, or either right hand or the left hand, which is very, very important, particularly in a patient who is unstable and where the pulses are low. Those cases, it is very, very important. The non-invasive continuous hemodynamic monitoring is always a good tool, and there are a lot of papers which says that these are the one of the tools which shows you the earliest sign of shock. Okay, and these are the different non-invasive cardiac output monitor which is in the pipeline, where just you need to put the finger probe of the monitor. This is one of the monitor is going to develop by different companies, and these are the continuous non-invasive cardiovascular monitoring tools. This is called the NextFin monitor or NextFin hemodynamic monitor. Though the precision is not that good, but still you can have a very good correlation with the trends, and you can see the cardiac output bedside once you put these monitors. So these are going to be the future, and most of the ICUs will be equipped with such kind of monitoring devices, probably in the next generation ICU, where we are going to lead. So the more important thing is, whenever we are measuring the cuff or blood pressure with a particular manual methods, ideally the size of the cuff is very, very important. Most of the times we forget that, and the small cuff can cause falsely high reading, and the large cuff can sometimes cause a falsely low reading. The auscultatory or oscillometric methods is very inaccurate, but the trend is sometimes gives you a clue. Significant underestimation in low cardiac output state. So whenever the person is in hypotension or shock, probably these methods will not give you the accurate reading. That is the reason we insist our registrars or our colleagues to always take a invasive blood pressure monitoring whenever the person is in shock state. So invasive blood pressure monitoring, these are the different connections, starting from the fluid filled non-compliant tubing more than 1.2 meters. There is a clamp, there is a sampling port, there is a pressure transducer. The pressure transducer should be kept on the level of phlebostatic axis in the mid-axillary line in the fourth intercostal space. And there is a flush valve which is always be there to do the first flush test. There should be a pressurized bag of saline. The pressure should be maintained in the range of 300 millimeter of mercury. And this is the ideal setting of a invasive BP monitoring. So any disconnection or any troubleshooting in any level can give you an inaccurate value. If the leveling is not proper, if the alignment is not proper, or if there is some air bubbles or some disconnection in the particular that circuit, that can give you a false value. Now coming to the interpretation, so this is a typical wave of a the blood pressure wave, invasive blood pressure wave. You have to remember that there is a delay of 180 millisecond between actual the fluid filled system to measure your blood pressure and actual the blood pressure wave which is generated in the system, because there is a transmission of energy from mechanical energy. The monitor has to convert it into a electrical energy or and display in the monitor. And all these principles are based on the Wheatstone bridge principle. So they may sometimes ask in the exam, what is the Wheatstone bridge principle? And this is different. Your arterial tracing, you can see the peak systolic pressure, the systolic decline. Here is the peak systolic pressure, the systolic decline, the diacortic notch, and this is the systolic uptake. And this is something called as the diastolic runoff and the end diastolic pressure. So there are 5 components in particular invasive blood pressure tracing. This is very, very basic for an intensivist to understand. And we see the area under the curve is nothing but it is the mean arterial pressure. So whenever you look at the blood pressure monitoring devices, always look for the area under the curve. This gives an idea that this is the mean arterial pressure for that particular patient. So we know that the mean arterial pressure is nothing but cardiac output into the stroke volume or systemic vascular register. Okay, so it is the mean arterial pressure which ultimately gives you the end organ perfusion, and this is also determined by another formula, the diastolic pressure plus 1/3 of the pulse pressure. So what is a pulse pressure? The pulse pressure is nothing but it is the difference between something called as your systolic pressure minus the diastolic pressure. So if you see, this is something called as your blood pressure tracing. Okay. And what is the blood pressure gives us? Basically, it gives us an idea regarding the vascular tone. So we can see whether the patient is vasodilated or vasoconstricted. And you see, in case of vasodilated patient, you can see both the arc, they come very much closer to each other. And in case of a vasoconstricted patient, you can see basically the area under the curve, that mean arterial pressure, the area goes up. So you can have a broader area in a vasoconstricted patient and a smaller area in case of a vasodilated patient. So this is nothing but this diastolic notch and the systolic peak systolic pressure. The difference between these two, the systolic pressure and the diacotic notch, is nothing but it is called basically the something called as the pulse pressure. So you can see here, in case of vasodilated state, the pulse pressure is wide. In case of a vasoconstricted state, the pulse pressure is very much narrow. So this is having a low mean arterial pressure, and this is basically having a high mean arterial pressure. And sometimes we can see the slow rise of the systolic peak. This is something called a slurred gradual systolic uptake, and absent diastolic diacotic notch, which is also a sign of something called as a narrow pulse pressure. So it also gives an idea regarding the contractile state of the myocardium. Like you can see here, the pressure increases as the blood flows into the aorta, and this is something called as the dP by dt. Okay, and if the dP by dt rise is gradual, probably this is something called as a low contractile myocardium. Compared to that, where the dP by dt is sudden, and you can see there is a sudden slope in the dP by dt, which is measurable, and this is probably something called as the more stiff dP by dt, something called as the high contractile myocardium. So this is one has to understand between both the difference. The systolic pressure variation, so something called as your SVV or pulse pressure variation or systolic blood pressure variation. So whenever the patient is fully sedated and paralyzed, the patient is receiving a tidal volume of 8 ml per kg, he is under positive pressure ventilation. There is a significant component to the heart-lung interaction, and because of that, the patient, if he is fluid deficit, he can show you a tracing like this. And this is called the systolic pressure variation or the pulse pressure variation, PPV. So when you attach cardiac output monitor to such patient, what you measure is called the variation in systolic blood pressure on mechanical ventilation. If the patient is hypovolumic, you can measure something called as the pulse pressure variation. And this pulse pressure variation, if it is more than 13%, or it is something signifies that the patient is fluid responsive. And this is something called as the delta pulse pressure. Okay, so you can see this is the systolic pressure of the peak of in the respiratory cycle, the changes in the pulse pressure over the respiratory cycle, which is called the delta pulse pressure, are calculated from the difference of P max and P min. So what is P max? Basically, it is the systolic pressure, maximum systolic pressure, pulse pressure, and your minimum your pulse pressure. That is called the P min. And basically the mean of the two values, the difference of the mean of the two values, if it is more than 30% or greater, 13% or greater, it significantly signifies the patient is fluid responsive, and those patients sometimes require the fluid. So all these components are attributed to the significant heart-lung interaction in a patient who is hypovolemic. So we have already conducted a class by Dr. Treble on heart-lung interactions in our previous lectures. And those lectures are very, very important to understand what is the significance of heart-lung interaction in a normal state, in an abnormal state. So we can see this is something called as the pulse pressure variation. And this is the typical aortic, your invasive blood pressure looks like. As one goes from aorta to the lower limb, like dorsalis pedis. So the characteristic of the waveforms looks like this. So in aorta, you can see the taller the systolic peak, the further the diacotic notch, the lower end of the diastolic pressure, that is the wider the pulse pressure. So in aorta, you can see basically the peak or the mean arterial pressure is quite significant. Whereas in case of dorsalis pedis, the mean arterial pressure, you can see the peak is high, but the area under the curve is gradually narrows down as one moves from the aorta to dorsalis pedis. This is because of the something called as the stiffness of the arteries, and this is also known as the distal systolic pulse amplification. So the systolic peak is stiffer the further down the arterial tree, and once you travel, this is all because of the reflected wave. So this is the sense, and this is the different troubleshooting with the blood pressure. Like this is the normal blood pressure, this is the overdamped pressure, and this is the third one is the underdamped pressure. So how to know whether your blood pressure, invasive blood pressure is underdamped, overdamped, or normal? This is by just performing a simple test, which is called the first flush test. So everybody has to know what is a first flush test. And as per that first flush test, one has to determine whether it is overdamped. So every duties when somebody comes, he has to ideally perform a first flush test to know whether arterial line is properly placed and your tracing is proper. So this is the different your interpretation for the first flush test. So when you do a first flush test, you can find these are the different kind of your test results. And here you can see this is one test results when the artery is underdamped. Basically, your system is underdamped. You can see this kind of results. And when the system is overdamped, then you can see this kind of results. So according to that, you determine whether it is underdamped and overdamped. And there are different causes of underdamping and overdamping. Saturation monitoring, continuous saturation monitoring is immediate detection of even a small amount of hypoxia. It is a bedside, and the saturation monitoring is very, very important because you know the oxygen hemoglobin dissociation curve is sigmoid separated. That is why when the PO2 falls below 50%, there is a significant desaturation or hypoxia which is going to happen, which is life-threatening. That is the reason we aim at keeping a PO2 of more than 50 or preferably 60, because more than 60, you are in a safe zone. Less than 60 PO2, you are in a very dangerous zone. But there are a lot of pitfalls in bedside saturation monitoring, like there can be a motion artifact because of shivering. If the person is having an intra-aortic balloon pump assistant, the saturation sometimes can go erroneous. If there are abnormal hemoglobins, particularly the carboxyhemoglobin, which gives you a very falsely high value of saturation, or meth hemoglobin, which can give you a falsely low value of saturation. When the saturation is more than 85% and falsely high, you can suspect that it is because of the meth hemoglobinemia. And particularly in such patient, we recommend something called as co-oximeter, which actually accurately reads the saturation. And sometimes if the person is having low perfusion state, your saturation may not accurately reflect. If the person is hypothermic, if there are skin pigmentation, if there are nail polish, nail coverings, or inability to detect saturation below 83%, with some degree of accuracy and precision seen at a higher saturation, but the level of discrepancy is not a clinical importance. That means once the person is hypoxic, your saturation probe may not accurately reflect the oxygen level. But if the person is having a normal saturation, most of the times the accuracy and validity is very good for a pulse oximeter. Capnography always gives you two important information. One is regarding the blood flow and cardiac output, and second is the ventilation. So if your ventilation is okay, your capnography gives you a very good results. If your cardiac output is okay, your capnography also gives you a normal results. So any condition where your cardiac output goes down or your ventilation is abnormal, you can see an abnormal capnography. So whenever your patient is on ventilator, ARDS, stiff lung, always recommend to use the capnography and ETCO2. So this is basically a capnography which says that gradually you can see there is a fall in the area under the curve of the capnography tracing. That means your cardiac output is gradually falling. So in a mechanical ventilated patient, when there is a sudden or serious cardiac impairment leading to cardiac arrest, your end tidal carbon dioxide significantly warns you that this patient is going to have an imminent cardiac arrest. Your end tidal carbon dioxide immediately goes to a level of 10 or 20 from 50. So that is a sudden reduction in your pulmonary perfusion, and that leads to significant drop in the ETCO2, your waveform. Central venous pressure. This basically tells us about the intravascular volume status, right ventricular function, and patient response to drugs. These are the different waveforms of CVP. all of us know. A is due to atrial systole. The C wave is because of the closure of the tricuspid valve. That is why it is called the cuspal. X descent is the X descent is basically because of the fall in arterial pressure during your something called as the ventricular systole. The V wave is because of the something called as the venous filling, and the Y descent is because of the opening of the tricuspid valve. Out of this, the A wave, C wave, and V wave, which is the most important wave, because the most of the times in a CVP monitor, what we determine the CVP is at the base of the C wave and at the end of the expiration. So most of the pressures are measured at the end of the expiration. And the normal value of CVP we know. So normally the CVP sometimes shows you a low value, but that doesn't mean that the patient is fluid responsiveness. The sensitivity and specificity of CVP in fluid responsiveness varies, but a high CVP always signifies that there is something abnormal. That is why you have to always very, very careful. And these are the CVP waves which shows that these are the different parts of the ventricular, your cardiac cycle. The person, when the patient is in the diastolic phase, you can see a wave. When there is a ventricular systolic phase, you can see a X wave, and there are visible pulsation also obtained. These are the CVP wave from interpretation. As I already told you, it should be measured at every pressure of the cardiac chamber should be measured at the end of the expiration at the base of the C wave. Then we can get the reliable CVP. And ideally, you have to take the three values and make a mean of the three values to determine your CVP. Minimizing errors. So always zero, level your transducer, mark level on the patient chest, measure always pressures in the supine positions, not in the lateral decubitus position, because that will give you a very falsely readings. Always interpreted CVP and pulmonary artery pressure by yourself. Measure the pressure at the end of the expiration. Trend is always more important than a single value. Never ever just the single value, always look for the trend. Do not set arbitrary CVP goals. Assess the response and consider ischemia. If there is some valve pathology, your CVP may not be reliable. So in such patients, do not measure the CVP. And these are the compartmental model of the body. Basically, we note that this is the heart, and the heart is surrounded by a lot of compartments. So actually, the pericardium, chest wall, the pleura, your something called as diaphragm, and all these pressures, they influence your pressure of the CVP. That is why whenever any pathology in any of the chambers, actually your CVP may not show you the reliable information. That is why the validity of CVP is very, very low. And you have to always consider CVP in relation to other pressures like intrapleural pressure or intracardial pressure. And sometimes you have to actually go for the proper filling pressure. So there are studies which says that CVP or pulmonary artery pressure do not predict the fluid responsiveness in a patient. And you can see that the false positivity rate is very, very high. So that is why they are not the only parameters, and these are basically called the static parameters of hemodynamic monitoring. Now on this next lecture, we'll go for the dynamic parameters, probably in some other class. Monitoring of tissue hypoxia, which is very, very important. Lactates, all of us know, it is one of the global measure of tissue hypoxia, and global measure of central venous oxygen saturation is also one of the measure of tissue hypoxia. So either you can know what are the global markers of tissue hypoxia or what are the regional markers of tissue hypoxia. So to know the global trend, we have to measure the lactates or mixed venous or central venous oxygen saturation. To monitor the regional hypoxia, we have different devices like sublingual capnometry, gastric tonometry, your near-infrared spectrometry, spectroscopy, transcutaneous oxygen tension, resonance Raman spectroscopy, or something called as OPS, orthogonal polarization spectroscopy. Serum lactates, the golden days, actually everybody knows the value of lactates and how important it to the intensivist actually. Elevated serum lactate level may represent poor tissue perfusion. The association of increased lactate level with circulatory failures is already established. And whenever the lactate levels goes more than 2, it gives you a warning sign that there is something tissue hypoperfusion is going out in the microcirculatory levels. But there are certain pitfalls in the lactate monitoring, like if the patient is already having toxicity with methanol, ethylene glycol, or propofol, or if the person is having a severe thiamine deficiency, or if the person is having a liver failure where the lactates, they are not getting cleared properly. Those cases, you can always get a falsely high value of lactate. Okay. And whenever the patient undergoes a cardiopulmonary bypass, there can be an elevation of lactate up to certain hours. There can be also exogenous source of lactate which comes to the body. Like if the person is already in a CRRT circuit, like lactate buffered solution used for CVV, SDF, or medications like metformin, or your AIDS medication or ART, all those medications or long-term linezolid use, intravenous lorazepam use, or valproic acid, they can give you a falsely high lactates. Many cases of hematological malignancies, you can also get a falsely, or you can get the lactate levels to be elevated. But those are not the signs where tissue hypoperfusion usually exists. And these are the pitfalls in lactate monitoring. Repeated measurements of lactate concentration over a times are particularly useful for monitoring the response to therapy. Okay, and ideally the lactate should get cleared easily with resuscitation. The more than 50% clearance of the serum lactate is a very good marker that your resuscitation is appropriate. So if your initial lactate is 8, it is coming down to 4, that means your resuscitation is proper. Mixed venous oxygen saturation, something we measure with the help of a fiber optic pulmonary artery catheter. And we know that the blood is collected from the pulmonary artery and sent for the analysis to get the mixed venous oxygen saturation. The normal mixed venous oxygen saturation is around 75%. And either side decrease of 5 to 10% is sometimes considered to be significant. Okay. And basically this depends on your cardiac output and metabolic rate and oxygen utilization. And these are the catheters which is used for measuring the mixed venous oxygen saturation. Central venous oxygen saturation, which is something measured from the superior vena cava or right atrium, peak of the superior vena cava and right atrium, that also signifies you for the global oxygen level or global your oxygen saturation. So there is a correlation between something called as your mixed venous oxygen saturation and central venous oxygen saturation and oxygen delivery and oxygen, something called as oxygen utilization. So in health, normally you want the oxygen delivery and oxygen utilization to be at par so that this balance should be maintained. But whenever your oxygen consumption or VO2 is less and or goes up, your oxygen consumption is more and oxygen supply is less, those cases you can find a decrease in the central venous oxygen saturation, like the second graph. Sometimes you can find a very high value of central venous oxygen saturation in condition where your tissue is not utilizing oxygen, like in the third graph, where your DO2 is maintained, but your VO2 or oxygen consumption is very, very minimal. In those cases also you can find supranormal central venous oxygen saturation. So any central venous oxygen saturation more than 85% or less than 55% is always abnormal. Particularly the lower values are more dangerous compared to the higher values. And in late stage of septic shock, your VO2 is very, very minimal and your mixed central venous oxygen saturation goes very high. These are the different, something called as the monitor to measure the regional circulation, like sublingual capnometry. The probes are available. You put it under the tongue and you measure the carbon dioxide tension, just like it is CO2, and something you interpreted the value. And this is something called as the PSL-CO2 gap, which is more important in such kind of scenario. Gastric tonometry, not routinely practiced. Index of aerobic metabolism in the gut mucosa. You can put esophageal balloon and you can measure this. Orthogonal polarization spectrum. And basically you can keep the probe in oral mucosa, sublingual mucosa, and rectal mucosa. And you measure needs, particularly very, very useful for patients where you want to measure different oxygen levels or saturation level at particular tissue level, like either you measure in the hand or in the brain or in the particular part. So there are certain probes which is called NIRS probe or near infrared spectroscopy probe, which are available and which can be applied. Any value which is less than 75% in NIRS interpretation is actually abnormal. And that has to be interpreted carefully. But all these monitors, they actually lack significant validity and reliability. It has to be correlated with other parameters, transcutaneous oxygen tension. So this also sometimes measure, but it is a little bit invasive technique. And you have to insert your probe just to the subcutaneous place to measure the subcutaneous tension. So with this, this is my last slide. So monitoring tools are many. So there is nothing to get confused, like this child, which is actually confused what to monitor, when to monitor, where to monitor, and where he want to go, basically. So the simplified interpretation is very, very simple. What you ultimately monitor is the shock. So either you have to differentiate whether it is a hypovolemic shock, cardiogenic shock, obstructive shock, or distributive shock. So you can imagine this diagram. This is basically the tank. This is basically the pump. This is basically the circulatory system or the pipes, and this is basically the exhaust pipe. So whenever there is any problem to the tank, there is no blood or no fluid in the tank, this is called hypovolemic shock. When there is any problem in the pump, this is called cardiogenic shock. Whether there is any obstruction to the forward flow and the pump is normal, tank is normal, this is called the obstructive shock. So the examples of obstructive shock is pulmonary embolism, pneumothorax, cardiac tamponade, where basically there is a forward flow obstruction, and distributive shock, where basically something called as the vasodilatory shock, where the problem is in the end organ level, in the capillary level. So it is very simple to interpret. So you have to only look for these 3 or 4 parameters, something called as CVP, pulmonary artery pressure, the systemic vascular resistance, and cardiac index. And as per that, you determine what is your type of shock in a particular patient. And this is the simplest thing which one can remember to classify the different types of shock in clinical practice. In cardiogenic shock, first thing is your CVP and pulmonary artery pressure both are elevated. Whereas in hypovolemic shock, your CVP and pulmonary artery pressure both are down, and your SVR depends on the type of shock in this particular way. So with this, I conclude the things, and just my take-home message is tachycardia is never a good thing. Hypertension is always pathological. There is no normal cardiac output. There is something called as CVP is only elevated in disease. The monitors are associated with inaccuracies, misconception, and you have to always interpret it in terms of clinical scenarios. The goal of treatment is based on monitoring to restore the physiological homeostasis. So thank you to my team, Akhilesh, Sukhdeep, and others delegates who are in the lecture. Thank you.
It was indeed a wonderful presentation, and that too on basics of hemodynamic monitoring. Thank you, Dr. Gunadhar, for this wonderful deliberation, and you have covered most of the topics. I mean, I think there is nothing left in discussion, but I would request the audience also, if they can put some questions, it would be quite great. But there are a few questions in my mind as to.
No, there are actually a lot of questions in the chat box. Subhadeep or Akhilesh.
Yeah, I would like to read those questions also, for you. And then I would invite Dr. Sukhdeep also for moderation. And the first question is about.
So in the chat box, sorry. So in the chat box, what we have done.
No, I can't export now. I'll tap in.
Yes. So to make it a little more interactive, we have created 5 quiz sessions. We have already got answers of a lot of the questions from the quizzes. So what we can discuss, we can just discuss these quizzes. There are different clinical scenario and different academic questions over there. And to just make it a little more interactive, we just started having this kind of quiz kind of scenario, so that everybody participates. And if anybody is having any kind of doubt regarding the hemodynamic monitoring, they can ask the questions over here.
So these questions we have framed in the form of some quizzes. These are in the form of MCQs. So I will read the question and the options, and I would expect the audience to come up with the answers. Okay, as many possible answers also is at times may be possible. So the question 1 is, about one patient. When we care for the patient, as far as small bowel affections are concerned, this assess the pulmonary artery occlusion pressure of 1 millimeter of mercury and hourly urine output of 5 ml. The nurse anticipates which therapeutic intervention? Okay, the option A is diuretics, option B is intravenous fluids, option C is negative inotropic agents, and option D is vasopressor. So we would expect the audience to come up with the answers. Please tell us what is the answer for this. What does the nurse anticipate as far as therapeutic option is concerned? POP of 1 and urine output of 5 ml.
So I think a lot of people have already given a correct answer over here. So here, evidently the pulmonary artery occlusion pressure is very low. So you can expect that and patient's urine output is low, somebody is oliguric, so we should give fluids. So there are 4 options: diuretics, IV fluids, and the inotropic agents in the vasopressor. So right answer over here should always be to give IV fluid, especially somebody's pulmonary artery occlusion pressure is very low.
Yeah, right, absolutely right. So hypovolemia is supposed to be corrected with the fluids, and that's the appropriate answer. Second question. The patient is admitted to the hospital with multiple trauma and extensive blood loss. The nurse assesses vital signs to be blood pressure of 80/50, millimeters of mercury, heart rate of 135 beats per minute, respiration of 36 breaths per minute, cardiac output of 2 liters per minute, systemic vascular resistance of 3000 dynes per seconds per centimeter, and hematocrit of 20%. The nurse anticipates administration of each of the following therapies or medication. Option A is blood transfusion, B is furosemide, C is dobutamine, and D is butanol. So what's the answer?
So I think here also everybody, a lot of people have given a right answer over here, what I can see in the chat box. So the clinical scenario over here is again the patient is hypovolemic, hypotensive, tachycardic. His cardiac output is low, his SVR is quite high. So he's a vasoconstricted state. So that means that the patient is lost a lot of blood. So it's a blood hypovolemic state because of this massive blood loss. So the first therapeutic intervention should be the blood transfusion. So blood transfusion should be the right answer over here.
Yeah, obviously, and the oxygen delivery it depends upon cardiac output, hemoglobin, and the oxygen that is supplied. So even a small change in the cardiac output can lead to substantial change in the oxygen delivery of tissues. At the same time, the change in the hemoglobin values can also lead to a large change in oxygen delivery. As you all are aware that oxygen is carried by the hemoglobin. Okay, if the hemoglobin is low, oxygen delivery to the tissues will be compromised. If you keep on giving fluids for the hypovolemic state in such a situation, that will again aggravate the problem because the oxygen delivery would again get compromised and hemoglobin again, even if the hemoglobin is low, it may get diluted and the oxygen delivery will be compromised. So it is the hemoglobin part of the oxygen delivery which has to be addressed immediately. And for that, the answer is blood transfusion. Here, increasing blood cardiac output will also not improve, and increasing oxygen support or increasing oxygen concentration will also not help. So the right answer is blood transfusion. Good. So the question 3 is, what does the atrial A wave mean, and which wave of the ECG does it follow? A, passive filling of the ventricle found on the T wave. B, atrial kick found just after the P wave. C, atrial kick found after the QRS complex. And D, contraction of the ventricle located at the ST segment.
So again, this question is very favorite to the, this kind of questions are very favorite to the examiners whoever is attending the IDCM or DNB practical exam in the Viva table. So everybody should be aware what are the different waveforms in the CEP tracing. Dr. Gunadhar has already told the different waveforms in the CEP tracing. So one of the important wave over here is the A wave. So A wave is always corresponds to the atrial kick, and atrial kick always happens in the ECG. It happens after the P wave in the ECG. We should know. So whenever we see a CVP tracing, we should know what are the waveforms we are dealing with. There are different waveforms we have, and based on the waveform pattern, we can identify various disease pattern in a patient. Like so, it's very important to identify the A waves, the V wave, X descent, Y descent, C wave. So these things are very favorite to the examiners as well, and you should know. And one of the important way to identify this waveform is from the ECG leads as well. So any waveform which happens just after P wave is A wave, and it corroborates with the atrial kick. So I think the B over here, the atrial kick found just after P wave, is the correct answer over here.
Yeah.
Yes, obviously. Yes, good. Thank you, Dr. Sudeep. So we have a fourth question. Yeah.
One of the very important basics and one of the very important questions actually. And most of
it is usually asked in the table viva.
Yeah.
Sure. So the fourth question is, what does the left ventricular end diastolic pressure indicate? Afterload, preload, congestive heart failure, or the option D is the end of the systolic cycle?
So again, so everybody should know this answer, and everybody should give a correct answer. I think whoever has given the answers over here, they have all given a correct answer. So left ventricular end diastolic pressure means the preload. So how we measure the preload in the echo is we need to measure the left ventricular end diastolic volume and the left ventricular end diastolic pressure. So and that is how we measure the preload, and that is the only way we can measure the correct preload. So LVEDP always synonymous with the preload of the heart.
Yes, and you know, if there is no valvular pathology, left ventricular end diastolic pressure is supposed to be equivalent to the pulmonary artery occlusion pressure. Okay, so these conditions are only considered in ideal situation if there is no valvular pathology. So even pulmonary artery catheter can help you to approximately measure left ventricular end diastolic pressure, because in an ideal situation, if the valve is normal, pulmonary artery occlusion pressure should be equal to left ventricular end diastolic pressure, considering these probabilities. But if there is a valvular problem, this doesn't hold true. Okay, so LV-EDP is the preload of the left side of the heart. Okay, whereas pulmonary artery occlusion pressure, if it is equivalent, it will also give us an idea that pulmonary artery occlusion pressure can be a preload of the left ventricle. So, any other question? Yeah.
Have we?
Yes, all the.
Have we discussed this quiz number 5 and 6?
Is
on the respiratory cycle is the optimal measure?
Yeah. I did. Yeah. So there is a fifth question also. So where on a respiratory cycle is the optimal measurement of optimal measurement point for measuring the pulmonary wedge pressure? End inspiration, you need inspiration and expiration and average them. End expiration, or option D is either one is okay as long as you adjust the measurement scale.
So answer to this thing is always we should measure all this measurement to have a kind of end expiration. So like we are measuring the pulmonary oxygen pressure or pulmonary capillary wedge pressure or whatever we are measuring. So all these measurements should happen at the end expiration. So this is again a very basic question. We should know that all these measurements happen in the end expiration, nowhere in the respiratory cycle, because that is when our intrathoracic pressure change variation, pressure influence on the CVP and the PCWP are the least.
Yes, Dr. Sundar, you are absolutely right. But this holds true only, we need to assess whether the patient is spontaneously breathing or patient is on mechanical ventilator.
I'm not sure.
So the next,
for somebody, nobody has given answer to quiz 5 and quiz 6. So I do not know what has happened. Previously,
but we will definitely like
enthusiastic. So I do not know why everybody has lost enthusiasm for the
they must have forgotten. Yeah, so basically, if the patient is spontaneously breathing, it should be measured at end expiration. But if the patient is on mechanical ventilator or he is on a controlled, controlled breath of mechanical ventilator, then it should be at the end of inspiration. So that's why we need to know the situation, whether the patient is spontaneously breathing or patient is on mechanical ventilation. So the next question is, which hemodynamic pattern aligns with the primary pulmonary hypertension? Option A is elevated right ventricle, large V wave in the right atrium. B is elevated wedge pressure, normal pulmonary artery pattern. C is elevated LVEDP, normal right-sided measurements. D is normal wedge pressure and elevated pulmonary artery, right ventricle and right atrial pressure.
So again, it's very interesting question. I am not seeing anybody has given answer to this question.
They have given the answer to fifth question.
Sixth question, anybody has given answer? Just one, let me check if anybody. Oh, okay. Dr. Tejaswini and Dr. Pooja has given answer. I think Dr. Pooja has given a good right answer over here. So Dr. Pooja is right over here because it's a primary pulmonary hypertension, the clinical scenario over here. When there is a primary pulmonary hypertension, the crux over here at this moment in this clinical scenario that we will have a normal wedge pressure because the circulation distal to the pulmonary artery is normal. But in this scenario, we'll have a normal wedge pressure, but elevated pulmonary artery pressure and the right-sided pressure, like right ventricular pressure, right atrial pressure will be elevated. So the D answer is the correct answer over here. So always we need to, so that is how we differentiate in right heart catheterization, whether if we find a right ventricular pressure is elevated or right PA pressure is elevated, in that case we see that we wedge it and we see that the pulmonary artery wedge pressure. The wedge pressure is normal, but PA pressure is high. In that case, it means that it's a pulmonary arterial hypertension. It's a pulmonary arterial vascular problem. It is not the left-sided heart problem. So that is how we differentiate the left ventricular failure and the pulmonary arterial, isolated pulmonary arterial hypertension.
Yeah, absolutely. Absolutely. So it is the pulmonary vasculature problem and not the problem of the heart. But the heart problems will occur once the pulmonary pressure goes very high and the compensatory changes fail. So then we will have obvious problems pertaining to the the left side or the right side. Mostly it will be the right side which will be affected most because the right heart has to pump against the resistance. So the right heart related issues will be more obvious, like elevation of the CVP, okay, or elevation of the pulmonary artery pressure, or sometimes pulmonary oxygen pressure can also be. So the clinical parameters, we are like forgetting. Dr. Sudeep, do you agree with me, or what do you think about the efficacy of clinical parameters versus the routine parameters that we have? The same question that I would like to have it with Dr. Gunadhar also. So what is your opinion? Because nowadays with the advanced monitors coming in, we are going literally away from the clinical gadgets. Should these gadgets be utilized more often, or we should fall prey to the advanced gadgets that we have all the time with us and which has made our life so easy? So what is your opinion?
No, basically all these the clinical parameters and the gadgets both are complementary actually. One cannot replace others. See, basically the bedside clinical examination cannot be replaced by the gadgets. You cannot just rely on the gadgets. Monitor sometimes can give you some false signal. The monitors can anytime give you a false report, and there can be always there can be a troubleshooting happens with the monitor. So it is your clinical sense and your monitoring devices which actually give you the best results for all these interpretation, and that is what is the standard of care, in my opinion.
Yeah, I absolutely agree with you. Clinical parameters can be a complementary to the available gadgets that we have. And one of the drawbacks of the clinical parameter, it varies with the subject to subject. Means there is a great subjective variability. And the sensitivity and the specificity of these clinical parameters can be 50%. Means if you toss a coin, it may be either head or tail, something like that. But going by only monitoring devices, it won't be sufficient. At times we have found out that we have been monitoring the patient on monitor and we have not examined the patient clinically, which would have given you n number of parameters which would have helped you in your clinical management of the patient. So it cannot be neglected or it cannot be substituted by any monitoring device which may come up now, or which has come up now, or which may come up in the near future. So, but it should be utilized. You should touch the patient. Even a simple, tender touch to the patient is quite sometimes will help you to guide patient's clinical profile, hemodynamic profile, whether the patient is fluid responsive. Even if on touch, if you feel that the patient is warm, probably patient is in sepsis, or if the patient is cold, probably patient is in the cardiogenic shock. But looking at the skin turgor and touching the patient can also help you about the adequacy of the resuscitation. Any other questions in the chat box?
Yeah, I don't think any question is there. I think last question is there. Yeah.
So it was really a lovely discussion and a great participation by the delegates also. Hopefully, we will have more such interactive discussion. Any word of wisdom that you would like to give to the audience, Dr. Gunadhar, Dr.
Yeah,
Sudhir?
no, just I would like to conclude. Before I conclude, I just like to say the next topic will be the very basic, like the airway management and different difficult airway society guidelines. So for the next Thursday, on mostly on the same time. So any change will be intimated. So please be attend the lecture next week. And my only message to all the trainees and the intensivists out here is that do not never forget your basic skills in examination, and do not let your clinical skill die while you are jumbling and floating in a sea of all the advanced gadgets. Because sometimes what we can explore is actually we also sometimes we surprised to see our basic clinical skill, and that can really makes a difference to the outcome of the patient, particularly in a setup where all these sophisticated gadgets are not available. So one should always try to develop more and more intuitions, impressions, forecasting, and the sixth sense in the clinical medicine, particularly the critical care medicine, which is very, very vital for the patient outcome.
Yeah, obviously, not only the clinical parameters, but your CVP, pulmonary artery, pressure monitoring, even arterial pressure monitoring. All these gadgets are complementary to each other, and has to be seen as a trend. A single value of any of these parameters, which has been discussed today in basic monitoring assessment, a single value has no meaning. So we should be able to assess the trends of the event. Okay, trends of the clinical examination is also very important. Similarly, trends of the CVP, trends of the arterial waveforms and variations, pulse pressure variation or systolic pressure variation. Okay, or pulmonary artery end-occlusion pressures. It has to be evaluated over a time, and then trends, even lactate. A single value of lactate has no meaning. So similarly, all these values have to be plotted, okay, over a period of time, and then we should be able to assess holistically. So never rely only on one parameter. That is one pearl of wisdom. Always look at the trends of the events, trends of clinical parameter, trend of CVP, trend of arterial pressings, lactates, okay, and use all these monitoring devices together. Okay, you can't rely only on one monitoring tool, but you have to use all these tools as much as you have with you, and together you try to assimilate the understanding of the patient's hemodynamic situation, and it will definitely help you to guide the institution of the therapy that is required when you have assessed clinical parameters or hemodynamic parameters holistically. With this, I would like to conclude the session today. And thank you very much to Dr. Gunadhar and Dr. Subhadeep for for the program, and hope to see you again. And goodbye, all of you. We will see you all in the next airway management lecture. Saying goodbye. Thank you very much.
Thank you, everybody.
Thank you, Subhadeep, Akhilesh, and thank you all the delegates. Thank you.